We are now on week 6. We're halfway through. So this week, as I said, it's a little bit lighter week, I think, in information. We're going to be talking about hematological, and children with cancer. I think cardiac respiratory is that big, hard one. I think as we go forward, they make more sense, and I think you can understand them easier. So let's go ahead and start. No, this week you have things due. You got your NCLEX questions due. You have another sim chart. I call them case studies that is due. Most of you are getting them done on time. If you see that grades aren't transmitting over and you've done it, just let me know. I can go in and look up grades so that you're not like with a 0 and then like Jessica with the grade book. Oh my God, 0. There went my KGA. Oh, we can't do that. No, I get that. I understand you. So anyway, let's go ahead and start out with our PowerPoint. So hematological, immunological sort of stuff that goes on with children. So one of the things about hematological, immunological, this is some problems that have to do with blood and your immune system. So we know that there's going to be complaints that come that children are going to make. A parent's going to say, hey, my kid, he's not as energetic. He's not this. Something's going on. He's getting too sick or he's bleeding. Something's happening, right? So we know a complete blood count, a CBC is all we need. It looks at, number one, it looks at your bleeding, right? Because we have a platelet count there. It looks at your strength and your anemic, which is your hemoglobin hematocrit, looking at that. And it shows your white count, which shows, are you being able to fight infections or do you have an infection, right? So we know all of these things can occur due to many reasons here. Sorry to put my phone on silent, not like me. So red blood cells. We know that anemia or iron deficient anemia will be the most common of all the hematological disorders in children. Now, let's look at that. What is anemia? And what are red blood cells? Why are we so concerned about these? Well, what do red blood cells do? They carry oxygen and iron to the body. So when you don't have nutrition, iron, you don't have oxygen, what does the body do? It slows itself down, tries to reserve its energy because they're going to get tired and fatigued very easily. And that's the big complaint that we do here, okay? Now, in children, our red blood cells, our hemoglobin, usually in adults, it's like 12, 13, 14 hemoglobin, right? In children, we accept a little bit lower. 10 or 11 is actually fine because children don't eat the way that they should, especially when we look at some age group, toddlers. Toddlers are the picky eaters. Those are the ones that are more prone to iron deficient anemia. So you have a child coming in, parents are complaining, fatigue, the kid looks tired, the kid looks pale. What am I going to do to assess this child? Believe it or not, when I'm looking at that kid, pale, tired, the symptoms, it sounds like anemia to me. I'm going to listen to the heart. Why? Because in anemia, there's not a lot of blood vessels that fill up the whole lumen of the vasculature, okay? So when you're anemic, you have less cells, so those cells bounce off of all over the place. So you hear this swooshing or a murmur-like sound in the heart when you're in severe anemia, okay? Normally, the blood just flows through and it doesn't bounce because there's no room. They're crowding each other. But with anemia, there's more albumin, there's more fluid between the spaces, and it bounces, and you're going to hear that going on. So, what is the body fighting? It doesn't have oxygen, it doesn't have iron. And then the heart says, well, maybe I need to beat harder, faster, right? That's going to help. But what happens? If we don't correct the anemia, the heart's going to keep on beating, and eventually they're going to go into cardiac failure because the heart says, hey, I'm tired. I'm over this. Okay. So, consequences of anemia, cyanosis, not enough oxygen, and growth. I mean, it could be cognitive and it could be just growth. It's not going to be where you need it to be because why? Nutrition, nutrition, nutrition. No iron, no growth. So this is a picture from your book, and I think it says everything about all the anemias that you need to know. If you look across the board, they're all basically the same type of symptoms, basically paler, and then you're going to see that weakness, tiredness. If you don't have enough red blood cells, you don't have enough stuff in your blood to make you get up and go, 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 do you? Because you don't have iron and oxygen. So decreased red blood cell production. That means your body's not producing enough, which means you're not doing something good enough in order for the body to be able to do that. The biggest one, iron deficient anemia. You're not eating enough iron nutritionally. You're going to have iron deficient anemia. The second one that we'll talk about is B12. You don't need to know the others, but yes, they're part of nutritional deficiencies. Now, decreased red blood cell production can also occur because the bone marrow's not working the way that it should. I think the worst of all the anemias is the aplastic anemia because it mimics like leukemia. And we're going to go into that in a second. Now, there's one that's an increased red blood cell loss. This could be just bleeding, gunshot wound bleeding out. I mean, that's getting rid of blood volume, but it could be a nosebleed. I've seen many, many, many children come in, and I worked in the ER the last 10 years of my career, and they'd come in with these children with having frequent epistaxis or nosebleeds, and they're trying to figure out why. Many times it could be a problem of a coagulopathy. So one of the ones that we see a lot is actually not hemophilia that you think, but ITP or idiopathic thrombocytopenia purpura. ITP, P for platelets, decreased. You don't have platelets, you're going to bleed. Signs and symptoms that you see, petechiae, purpura, bleeding, nosebleeds is the big one, right? This is the one where they come in, nosebleeds, you take the CBC and you see platelets are low. Now you know why. They don't have blood, why their nose is bleeding. You need to correct ITP. We'll go into the treatment in a little bit. Increase red blood cell production. Number one, sickle cell. Sickle cells, they form them, they're great. They're shaped like a sickle. They're not normal, but the bone marrow produces. All right. So the problem, they die really quickly. So they're producing cells, they're sickle, they're non functional, and they die quickly. The other one we'll talk about is thalassemia. I actually call these the triangular type cells. And what happens in thalassemia, this red blood cell just bursts, and that's how it dies. But what is in that red blood cell? What did I just say? Iron and oxygen. So, what is going to be one of the big concerns? Yes, hypoxemia, but iron. They're going to be getting overloaded with iron. They're going to probably need chelation therapy, which is to remove the iron. They're becoming toxic. It can go to seizures and death, even just from their own blood. Yes, they can. So, chelation therapy, we'll go into that more in a little bit second. And the other type of red blood cell production is just when chemotherapy. You're getting toxic substances, you're trading off, getting rid of this one, but you might kill some normal cells, but it's what has to happen. Or it could be like a major overwhelming infection, which will cause cells to die. So, how do we take care of anemia? Well, doesn't it depend on the child, number one? So let's ask the mother or that child if they're old enough. So, what's been going on with you? Have you been tired lately? Are you eating properly? Has your nose been bleeding? Do you got ecchymotic areas, purpura, petechiae, all of those things? And to address anemia, how do we look for how bad, quote, the anemia could be? And it's as simple as the CBC again. And now we've seen that the CBC hemoglobin is 7, hematocrit's 21. What do we do? What's the treatment? Well, we can treat the symptom or find out what caused it. I'll always say that. Is it a symptom or is it a cause? So the symptom is this child has no red blood cells, has no blood volume, they're tired, they need something. Treatment, let's first of all find out what caused it. And bleeding could be causing anemia, right? So number one, no matter what age, we'll be doing a stool for hemocult. Let's make sure they're not bleeding out of their GI system. That could explain a low hemoglobin hematocrit, couldn't it? So if it's very low, even down in the emergency room, which you usually don't, unless it's big thing, we'll be giving and starting a transfusion because they need it that quickly. We'll putting an IV in. We'll be giving replacement fluids. Let's pull up the volume, in the blood, give it as much as it can, and they'll put some oxygen on the child. Now, I'm going to tell you, I've heard both stories about oxygen. Does it work? Does it not work? Well, if you don't have cells that carry oxygen, is it going to work more to give more oxygen? It's a question. But I've had some of my ER physicians say, give it. And some say, it doesn't matter if you want to put it on. It's not going to help anyway. So again, it's a personal choice. Oxygen doesn't work. But the big thing with it, you have a child anemic, keep them calm, keep them resting. Don't let them expend any energy that they don't need to, expend. Keep them relaxed because they have no energy. So, assessing this child. How old are they? Oh, racial background. Why would we look at that? When we look at sickle cell, it's African Americans, right? When we look at thalassemia, it's Mediterranean people or people from that area. So that's going to give us a clue of something. Of course, you're going to see what's been going on, how long it's been going on. And yes, stool for occult blood. That has to be done. Let's rule out a bleed in the gastrointestinal tract before we even go further in investigation. When we have anemia, we're going to have to be sticking this child for blood. We might have to give transfusions, might have to give iron injections. We might have to do all this stuff. So prepare the child on their developmental level, like we've already discussed there. I've already said, everything you do, make sure you decrease the tissue oxygen needs, which means keep that child calm. Don't let them cry, get upset, go bonkers when you need to draw blood. Pull him into it, let him help you, because he can, with all of this screaming and yelling, have a very serious outcome from that. So iron deficient anemia, most common. Mentioned it a couple times already. So what happens? Well, the child or adult is not eating enough iron in the nutrition that they are eating, okay? Now, usually young children don't get iron deficient anemia, especially the infants. And why? Well, we know initially it's breast milk or iron fortified formula that prevents anemia. And when we get to be 6 months, we start to feed foods that are rich in iron and iron fortified cereals. So we know that those babies usually get enough of what they want. We know iron deficient anemia can be caused by the mother says, all right, no formula, let's put them on milk. Milk doesn't give them what they need, doesn't give them the iron. So that can cause a problem, all right? So how do you correct? Now, this kid's now getting to be that toddler, starting to be that kid's closing his mouth, don't want all those green leafy vegetables and all that good stuff that has iron in it. Well, we might need to give iron supplementation. Do you remember how to give iron from pharmacology for a child that's a liquid? Well, remember, it is brown and it stains through a straw so the teeth don't get all stained on an empty stomach. Why? Because the iron must be digested by the gastric acid to make it usable for the body. So, empty stomach. And then let's give them some orange juice with it. It's another acid that helps speed up the digestion process, right? So before meals, empty stomach, never, ever, ever milk. That coats the stomach and prevents the gastric acid from breaking down the medicine and making it usable. Okay. Now, if this kid's not going to take iron, because it can happen, they might be getting the IM iron dextram. Remember, again, it burns the skin and it is it discolors the skin. So this is a deep IM Z track. So that I call it a lock and load. Pull the skin out, put the syringe and put the medicine in, pull it out, and close up that and lock and load. So sickle cell anemia is caused by both parents having a trait. You don't have to have the disease to get sickle cell. Both parents need the trait. And then every child has 25% chance of having the disease. So what is sickle cell? Sickle cell is sickle-shaped cells that the bone marrow produces in the body. And what's the problem with that? Well, they're not round and slippery and they can't just slide through all the blood vessels. They get to these bifurcations in the blood vessel and they get stuck, and one cell gets stuck and then the next cell and all the way back, and then all of a sudden the blood's building up behind it because it can't get through because that cell is stuck, causing pain, swelling, redness, and it hurts a lot. Okay, so what do we do? What is our treatment for sickle cell? Again, you want to treat the cause or do you want to treat the symptom? And our symptom is severe pain. What's the cause? A cell is stuck and it can't get through the blood vessel, creating a dam that's pushing all the blood vessels behind it, causing swelling, and no blood's getting down to, and let's say if it's in the knee, the toes. Now the toes are getting in pain and they could become necrotic and they could die if we leave it going on and on and on. So, what is our treatment for sickle cell? We got to get those vessels bigger, don't we? So, priority IV fluids, get the blood vessel bigger, give those cells a chance to get through, put heat on it, dilate it. Let's give a chance for those cells to get through. In the other hand is my pain medicine. And in the other hand is my IV antibiotic, most likely. So, priority, remember it, fluids, because that is causing the problem. So, what causes sickle cell? The biggest reason is dehydration. So, what do you think we're teaching our children at all times? Hydrate, 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 hydrate. You want to go for sports? It's fine. You could be active, be normal, be a normal child. Just hydrate, 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 hydrate. And when you get a fever of 100.5, call that doctor immediately because you are immunosuppressed and you must be placed on an antibiotic immediately. Now, this is sickle cell. Any immunosuppressed patient of any type, they get a fever of 100.5 or greater, you must tell them to call the doctor to be placed on an antibiotic. They don't have an immune system to fight. They are immunosuppressed. Okay? Understand that? So, sickle cell, let's hydrate them. They've got a fever. We're going to start antibiotics. And most of the time, these crises are due that. And of course, we always know stress. Absolutely, stress, trauma, those can cause it too. So, what did I tell you earlier about sickle cell and the red blood cells? They die quickly, right? So, these kids have no iron, they have no oxygen, they have no energy. If I get a sickle cell child when I was working in the ER, they had a hemoglobin of 7, I'd be happy. They come in at 4, 5, and 6. I'm talking really low. These children are so pale, they can't even hold their heads up. They're so tired. These children will get immediate fluids and blood in the emergency room as quick as we can get it into them. Now, as I said, Pain medicine is always in my other hand. And then you're going to say electrolytes. Well, it's not your priority at first. We're going to start the IV. We're going to draw the labs from it. We're going to start the bolus of fluids. We're going to give the pain medicine. We're going to give that antibiotic. And then we're going to look for the electrolytes because the potassium is going to be crazy. And we know it. We just got to go looking for it, right? But it's going to take time. They're probably going to be on a monitor because we know and we need to monitor that. Now, young children are placed on prophylactic antibiotics because, again, they're immunosuppressed. They don't have immune systems yet, especially the young kids. So, from 2 months to 5 years, they get, and usually what I see is one dose of PenVK. It's a penicillin, one pill a day. And that does help keep infection away from them. These children are always checking their reticulocyte count, making sure they're producing cells, of course. And of course, blood transfusions are given, and they get quite a few of them, especially when they're in severe crisis. Now, there is no cure. I've seen a couple of kids go in for bone marrow transplantation. I've seen it work both ways. I've seen rejection and I've seen work well. So it's a choice by the family. Again, the big thing that's the issue is those bacterial infections, and that's what will kill the child. As in, if they have a fever of 100.5, they cannot wait to call the doctor or go in and get medical treatment. They can live forever, but they've got to be really prudent. So seek early intervention, give that penicillin, and there's two sickle crisis attacks that are more dangerous than all the others. And one is a headache, it could be stroke. Chest, it could be a pulmonary embolus, or it could be a coronary artery, something going on there. So those are the two big ones you will always tell the doctor about. They're going to have swollen hands, swollen knees, swollen elbow, all of those things they're going to have. But when it comes to almost a stroke or almost heart attack, priority, right? Tell the doctor. And again, these kids, treat them normally. But again, send them out with a bottle of water, right? Keep them hydrated. The other cell, rectangular shaped cells, they're a little bit different than sickle cell. The rectangular shaped cells of thalassemia, these are mostly descendants of people living near the Mediterranean Sea. So again, that's why we do that assessment. Where are you from? What's your culture? What's your background? What happens is these cells have a very short life. The spleen, bone marrow, it produces them, but they're rectangular, they're not good shapes, and real quick, they burst. So now you've got all these red blood cells bursting into the blood system, their insides. What's inside a red blood cell? Iron and oxygen. So they'll be hypoxic, but they're also, this child's going to be getting more iron toxic and going to need chelation therapy. That's thalassemia. Now, they say there's 4 types, but when you're tested, they're always talking about the worst type, thalassemia major or Cooley's anemia. This one, believe it or not, the only way they can live in their red blood cells is transfusion. They don't make their own. Usually, what they do is they take out their spleen to try to help them. So, how do we diagnose thalassemia? I mean, we have those before the baby's born testing, to figure out about many different things today, but not thalassemia. So, at birth, the blood cells look normal. Why? They're mommy's. Mommy didn't have thalassemia, therefore, blood cells are normal. But somewhere about 6 weeks of age, that's when the cells change. So now at 6 weeks, iron is going out, iron and oxygen. What's happening? The body's not getting nutrition. Cognitively, they're going to be behind, and height and weight, they're not going to be grown. It's going to be that failure to thrive. And that's saying, oh, what's going on here? To the CBC, and we'll see it. It's that evident at that age. As I said, they're going to need Cooley's anemia. That's the worst of all. They need transfusions to live. Many of them, there's, little therapies in between. But again, thalassemia, we talk about when they get the transfusions. As I said, if this iron is bursting inside their vasculature, they cannot keep it there. That iron will go into toxic and it will cause seizures. So we need to get it out. There is a medicine called defoxamine or Desferel, and it combines the iron, attaches to it, and they urinate it out. So it gets rid of the urine so they don't become toxic. There's also apheresis. It's like a dialysis, but the neat thing about apheresis, it only pulls out the component that you want to come out. I just want platelets. I just want iron. What do I need? And that might be done too, depending on severity. So, how are we going to care for this child? This kid is chronically getting stuck for, looking at CBCs, also getting all of these blood transfusions. What about all these blood transfusions? When you get one, now you've taken somebody else's blood. So there might be other stuff in there, right? Called antigens. What happens with somebody who's chronically getting blood transfusions? And it depends on the child, the person, how frequent. I don't know how frequently. It could be every week, could be every month. I don't know. Depends on the child and how quickly those cells go. Remember, with all of those blood transfusions, they're going to end up with a very rare blood type. And that is usually the problem. So if we don't do that, we still can get blood all the way along, they can live. But if you can imagine, think about the heart and the blood. So we give a blood transfusion. Hemoglobin's up, heart's beating just 9. Very fine. Normal, normal, normal. Well, the cells start to die. Hemoglobin goes down. The heart says, whoa, wait, we need some oxygen and iron. Let me beat faster. So now you're going fast beat, slow beat, fast beat, slow beat. And it's the heart goes into failure. And that's usually what kills these patients, these children, because of that heart working, not working, overworking. And it's so confused. And because of the iron and oxygen in the body. They sometimes, well, as I said, will take out the spleen, but again, it could be going into a post-splenectomy sepsis. They're immunosuppressed again. All of these conditions are immunosuppressed, and that multi-organ failure. They say maybe a bone marrow. Again, it's really, really uncertain. So aplastic anemia. As I said, I think this is the worst of all the anemias. This is my opinion, because it affects red blood cells, white blood cells, and platelets. So if it affects the white blood cells, what is it affecting? Not enough white blood cells. It's also called leukopenia. No white blood cells, I'm apt to get infected, right? Then it also has a decreased hemoglobin. Red blood cells, they're low. What's happening there? I'm tired, right? I have no energy. And then the third thing, low platelets or thrombocytopenia, low platelets. I'm going to be bleeding. So pancocytopenia is the one you need to know here. There is another one that's a little different, but the one that we're discussing is pancocytopenia. How do we treat it? Just like leukemia. This gets the chemotherapy, immunosuppressive therapy, maybe a bone marrow to help. Okay, now defects in hemostasis, or this is what we call bleeding. So one of the big bleeding conditions is called hemophilia. Factor 8, factor 9 is the big ones, and von Willebrand's disease. This is caused by mommy. 80% are the inheritable pattern X-linked recessive. Mommy gives hemophilia to her children. As I said, there's A, B, and C, or factor 8, factor 9, or von Willebrand. Now, get a child in, and we're seeing signs of bleeding. As I said, a lot of times epistaxis is going to tell us, hey, something's going on. Not the first time, not the second time, but they continually to have nosebleeds. we're going to do that CBC, and we're going to be looking and trying to rule out these bleeding coagulopathies that are going on. So when these children come in, we're going to be drawing a bunch of labs. I mean, factors and all that good stuff. But they don't come back. They're too, what I call them, they go to send out labs, specialty labs. And sometimes it takes a week to get those numbers back to make a determination. Is it factor 8? Is it factor 9? Is it whatever? But when we have labs, a CBC, a PT, and a PTT can be seen immediately. So, what are we going to see with hemophilia? We are going to see, we're not going to know the factors yet. We're going to see prolonged PTT time. So it should be up to 40. It's going to be 400. I mean, it's going to be prolonged. And a normal platelet. Remember, platelets affect bleeding too. The other levels, you might get them right away and they might take some time, but you see a prolonged PTT and you see platelets normal, it could probably be your hemophilia. So treatment. You have a kid diagnosed, they have hemophilia, and they fall down, hit their knee, and their knee is just bleeding. It's bleeding, and they're at home. So, what are we going to do? Well, this story, just like that, happened to me. There was this little 8 or 9 year old boy who came into the ER one Saturday morning with his father. And he had fallen down and his knee was quite swollen. And he had his factor 8 with him, but didn't know if he should give it. He tried to call hematology, and his doctor wasn't answering. So he went to the ER to ask what should he do. Our doctor said, give it. Well, this father said, do you mind if I give this to my child? We're used to this. We do it all the time. And I said, do you mind if I watch? And I did. I had an orientee, a brand new nurse orientee with me. And I said, can she watch with me too? And I watched this father do probably the most amazing, meticulous, like washed his hands, used the alcohol. The son chose the site in the arm where he's going to stick this butterfly. He had to take powder in factor 8 with a liquid, mix it, roll it between his hands, pull it up in a syringe, and then he injected it through a butterfly needle. Actually, the son held on to the butterfly as he pushed this stuff in. It was probably the nicest thing I've ever saw. And the kid wasn't upset because he chose it. The father did it. We watched and we thought it was the best thing we ever saw. Now, sometimes there is a milder hemophilia and we can use nasal spray, but usually it ends up with the IV that we need to start it. And we give this when we have a bleeding episode. This kid fell down, hurt his knee. It was swollen, it was large, it was painful, and it was due to bleeding. So, kid fell down at home. What is he supposed to do? Well, first of all, he needs to stop, sit down, rest, as in slow down the heart rate, right? Don't get upset, don't get nervous, slow the heart rate down so the bleeding can be decreased. Heart rate elevated, bleeding more. So stop. Then let's do everything to do to stop the bleeding. Let's ice it, constricting vessel. Let's put an ACE bandage on it. It's like putting a finger on a sore that's bleeding. It'll stop the bleeding. And then, of course, elevate it above the heart. And that makes it harder for it to bleed. Now, what is the P? The P is when you have a young child just diagnosed with hemophilia, that you protect them, as in take your home, put, if you have sharp edges anywhere, putting cushions on them, like the coffee table, making sure that that child, if he rubs against it, brushes against it, he doesn't cut himself and bleed. So hemophiliacs can live like a normal life. The thing is, when they bleed, they need to take care of it immediately. And the reason is for instance, many times they fall down, hit their elbows or hit their knees, and they bleed into side joints. And blood is caustic, and it will attack and kill these joint sacks. So, and then they become crippled in wheelchairs and can't walk. So If we treat it early, take care of it, these children can live and do well. They are working on gene therapy now, and they're pretty close with it. Now, another bleeding problem. This is the one also that can be happening from my epistaxis, okay? So, kid comes in, epistaxis. We did the CBC, and you know something? Platelet counts are 20,000 or less. Like, okay. Then, when we look at this child, and this is what I hear from parents, I've seen quite a few of these, believe it or not, this immune, thrombocytopenia purpura. Well, these things, they come in and they're telling me the kid has bruising, has purpura, rash all over. The kid doesn't go outside, doesn't play, plays on his iPad all day, and why is he bruised? Because he didn't do anything. That puts up the red flags. So then I start asking, has he been sick lately? And usually they've had some sort of upper respiratory in the last couple of weeks before that. So, to the CBC, platelet counts are 20,000. Any any patient with platelets 20,000 and less, you must put them on bleeding precautions. What are bleeding precautions? Well, you are not going to stick them with a needle, so avoid venipunctures. You also are going to watch that child. Nosebleeds, bleeding gums, urine blood, stool blood, checking for bruising, making sure there's no more coming up on this child. Also, they'll be doing blood counts every day on that child because we are going to be giving IVIG, IV immunoglobulins, and something called anti-D antibody. And these things help the body start to reproduce platelets, and then the kid comes normal. Now, if it lasts over a year, they call it chronic. But usually, this is something we can cure. It's an acute illness. We can take care of it and we can fix it. So, we'll be monitoring those CBCs, monitoring if the platelet counts are coming up. And this says sometimes corticosteroids are prescribed. I've not seen them not prescribed. Epistaxis is probably one of your NCLEX questions. Remember the biggest thing with children with nosebleeds, epistaxis. The first thing is to calm the child down. As I said, heart rate up, blood pumps more bleeding occurs. Calm the child down, then that bleeding is going to be decreased. So, number one, sit him in mommy's lap, do wherever he wants to be comfortable. Then you take your thumb and forefinger, hold it and lean forward, and then hold it for 10 minutes. If after 10 minutes bleeding is still happening, they need to get that child to medical treatment. They might need to go to OR, cauterize, they might to put nasal tampons, something's going on. Or maybe we are going to be diagnosing leukemia, or we're thrombocytopenia, or ITP, or one of those other things, right? Why do we lean these kids forward as we're holding their noses? They used to say hold them back many years ago. Forward so they don't swallow their own blood. And then they'll be vomiting blood, and we don't want that. Okay, let's get into some immune stuff now. HIV and AIDS. Children, do they get HIV and AIDS? Sure. We know babies can be born from a mother of HIV, and we know older children, we hope they're adolescents, or might be into risky sexual behaviors, and that could cause it too. So, how do we help this newborn baby be the best and healthiest it can be? Well, what they say is at 22 weeks, up till after they're born, that they're placed on this highly active antiretroviral therapy. Okay. What the goal here is to improve the newborn's immune function. I've seen a couple kids born of a parent with HIV/AIDS, okay? One of the children I took care of was actually part of a triplet. And this is one of the clinicals that I taught. One of the twins had AIDS. One of the twins had HIV, and one of the twins had nothing. What they say and what I've seen is if we do this therapy and we continue it after they're born, many of these children auto convert back to no HIV by 1 year old. So, again, it's worth doing that. So, we know our goal with a newborn, they have no immune system. They only had mommy stuff, right? And if mommy stuff is HIV, we need to give this kid something. And that's why we give those antiretrovirals. Let's give that kid something to improve their immune function. That's the whole thing of this right now. The most common of all conditions that these kids can get is that PCP pneumonia. It's an opportunistic type of pneumonia, and where they go into it. Some people want to say it's that candida thing, but no, it's that PCP pneumonia. So, treating hematological problems, how are you going to do it? Well, we know transfusions, I've talked a couple of times about them. Transfusions can be of many different substances. It's not just packed red blood cells or whole blood. There's platelets, there's FFP, there's plasma. I mean, there's all sorts of different components on it. Our job as nurses is to administer it according to whatever that hospital has set up as their policy and their procedure. I mentioned apheresis. That's the one we did with the iron. We can remove all different stuff, or even platelets. Like some people, let's say I wanted to give platelets to my son who has ITP. We have the same blood. Well, I could go to apheresis, get the platelets of mine and give it to him. That's what apheresis does. We know with any hematological, the possibility of bone marrow is great because we need to see how those cells are being produced in there. And remember, that hurts a lot. They take this big, thick, huge lumen needle and it's like on a T, and they take the top and hold it and go, and you could hear it sound as it goes through the hip bone or into the sternum. These are the places that we would do this. Usually it's the hip bone on the kids. Again, we're going to give them sedation. Yes, they're going to have numbing stuff on top and they're going to do deep infiltration, but it's still going to hurt a little. You're going to hear me say it many times, but with children, if it's going to hurt, please be honest. Let them know, but also tell them you'll do everything possible to make it hurt as little as possible. So when both parents have sickle cell trait, what's the chance that each of their children have sickle cell? Anybody? I'm not answering it.
50%?
25.
25%.
25.
Yep, 25%. Both parents, only the trait. 25% will have it. So let's go ahead and let's start our first cahoots. Which way did it go? Hold on, I'm getting there. I'm coming. I needed to sign in again. Here we are. I'm gonna run quick to the ladies' room, everybody. Okay, let's start. Hematology. 32 questions. What is priority treatment for a newborn of an HIV positive mom? So, the big thing when we talk about HIV, AIDS, we talk about newborn, we talk about treatment, it's all about let's give this kid a chance. Let's improve that immune system. What kind of hematocrit would someone with sickle cell have and why? Up, down, which one? Why? Remember, sickle cell and thalassemia, the cells die quickly. Just think about these are cells that are irregularly shaped, so they just don't make it. They don't have the chance like regularly shaped cells do. So sickle cell, thalassemia, they die burst really quickly. That's why their hemoglobins, hematocrits are going to be quite low. What is the nurse's priority with a child with sickle cell disease who is currently experiencing a crisis? What do you do first? Priority. Are you going to treat the symptom or are you going to treat the cause? That's the answer to this one, isn't it? So you treated the symptom. What is it caused by? It's caused by a clogged blood vessel because something hooked up and now all the blood vessels are behind it and it can't get through the vasculature. How do you take care of the reason why they have the crisis? Dilate the blood vessels, give fluids, give heat, get it through. And as I said, in the other hand is my pain medicine. I know that they hurt, but let's treat why, not just the symptom. Okay. What is the reason children with iron deficient anemia are tired easily? So, iron deficient anemia, you don't have red blood cells. No red blood cells, you don't have oxygen, you don't have iron, and I'm tired. Good job. A multi. The nurse is teaching about newly prescribed iron supplementation. What should be included? Okay, iron through a straw on an empty stomach, and orange juice helps the acid and gastric acid break down the iron to make it a product that the body can use. It's through a straw because we don't want those teeth to get brown. The other thing we tend to forget is please tell the parents and the child when they have a stool that their stool is going to turn this black. Can you imagine not telling a child and all or the parent and all of a sudden your 2 year old has this black stuff coming out of them? You're like, oh my God, my kid is dying. Don't do that to the child. Don't do that to the parent. Just let them know it's normal. So they're going to be looking for it. Oh, look, it happened. Good. It happened. I'm doing good. As I said, never with milk and never after or during meals. Before. We need all that gastric acid. Aplastic anemia includes a depression of which blood cells? I told you it's the worst one. So, aplastic anemia, red blood cells, they're anemic. White blood cells, they get infections easily. Platelets are low, they bleed. That's what you need to know about these three type of cells and what they do and what to look for. Whether it's aplastic anemia or platelet counts of 20,000, these are the three cells in hematology that you need to know what happens. Most common type of anemia is iron deficient anemia. Yes, it is. What causes pernicious anemia? It's the intrinsic factor, isn't it? I don't even know why I remember that. So that is a B12 deficiency. Remember, that's from the stomach. The stomach gives that to the body. So, what is a symptom of B12 deficiency? We know what we need to do to treat it is to give B12 injections or increase the food that has B12 in it, right? It is a beefy red or sore red tongue. It's the tongue that you look for. Very good. What symptom is the single most common symptom of anemia? What do these kids complain of the most? Fatigue, because there's no iron, there's no oxygen, they're just running on empty. Very good. What teaching when teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? What's the problem with thalassemia? What do we watch out for? That's what that's asking. What happens in thalassemia? Remember, thalassemia are those rectangular cells, and the problem is they die quickly, but they burst. And what's in the cell is iron and oxygen are released in the fluid into the body. Okay, so our concern is they're going to be hypoxic because you don't have the cells with iron, and then that iron overload. They're going to need chelation therapy. So thalassemia, they need transfusions. That Cooley's thalassemia needs transfusions to live. You have to be careful because they're always lacking oxygen, and then they're going to be on medicine or apheresis to help get rid of the iron because of those cells bursting in their body. What lab values will you see with hemophilia? How do you know you have hemophilia? What did I tell you? As I said, you don't get those factor 8, factor 9 things back. Those are a specialty lab, as they used to call them. Take about a week. Can you wait? Kids got hemophilia. So what we see is a prolonged PTT, and the PT and platelets are normal. So this is giving you a good clue to what is going on. What is immune thrombocytopenia purpura? ITP. ITP, P for platelets. Platelets are low. Platelets are low. It's a bleeding problem. You're going to see hematomas, epistaxis, purple rash. This is what you see. Thrombocytopenia can cause the following problems. What is thrombocytopenia? It's another word for low platelets. When you have low platelets, what do you see? You're going to see that petechial hemorrhage, the ecchymosis, epistaxis. Very good. A multi. Child with hemophilia has fallen. His knee is swollen and painful. Treatment would include, what does that kid need to do? He's fallen. He's bleeding. Remember that price, that acronym, okay? Protect is when you protect your home when you first learn, but it's rest, ice, contain, elevate. If I put a hot pack on a child with hemophilia, you would dilate the blood vessels and he'd be bleeding more. So you put cold on it. What is the priority nursing action for a suspected blood transfusion reaction? What do you do first? I've seen some blood transfusion reactions in my time, and you know something? It's usually the first 15 minutes they go from no fever to 101. That's the reaction that I have seen most of the time. I've not seen anaphylaxis. I've not seen overload or those things. I have just seen a fever, quite a few of fevers. Anyway, you think something's going on, turn it off. Get rid of it. If you suspect, get rid of it. You pack it up. Yeah, sure, return it to the blood bank, but turn it off. That's what you need to do. A child is admitted with neutropenia. Which nursing action takes priority? What's neutropenia? Neutropenia is a decreased white count, which means you're susceptible to getting infections. So, what do we need to do priority? Wash our hands. Simple as that. When distraction is used, it helps. I always throw this stuff in. I want to keep you making sure you remember this stuff. I think I'm an expert on distraction, but remember, when you let a kid sit there and think about they hurt, they're going to sit there and hurt and they're going to whine and cry. Distract them with something, a game, a play, a stick or something. This kid forgets about they hurt and they want to play with that, whatever it is. What assessment question needs asked to a child with possible rheumatic fever? Now, this is a question that could be left for the next part of our lecture or last week, right? But what is rheumatic fever? What is it caused by? So remember, rheumatic fever could be caused by a strep infection. So any sore throat, they don't know if they've treated it or not. That's probably it. Remember, rheumatic fever attacks the heart. That's the worst part about it. Remember, it attacks the valve. All the other symptoms will be taken away with long-term antibiotics, but the heart valve will always be damaged. It'll have to be treated medically or surgically. Signs and symptoms of asthma. More from last week. Little bit of everything, coughing, shortness of breath, and don't forget, asthma is expiratory. They can get the air in, can't get it out. It's that croup, that's epiglottitis. I can't get air in because it's up here where the swelling is. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? Which ones are really you're concerned about? I mean, he knows there are going to be certain things, but other stuff is pretty dangerous. Our big concern would be a stroke or something with the chest pulmonary embolus. That's what we worry about. We know sickle cell is going to have swelling hands, the feet, the ankle, the knee, the whatever. We also know because of this thing that they might have sores that do not heal. The things that we really need to report is these abnormal things that could be dangerous, the headache and the chest pain. What are the odds two sickle cell carriers would have a kid with a sickle cell? We know that now. It's 25%. Good job. A position for a lumbar puncture for an infant or a young child. Because we do it all different ways depending on age. So these kids, we put them on their side, we bend their knees up to hit their chest. We open up the spine by bending them like that. And I was always the one that would take my arms and hold them and hug them. And I would talk to them as we're going, tell them, oh, he's going to touch you back there. You're going to feel a tickle, tickle. Tell me if you feel him touching you. And then it would be, oh, it's not a big deal because they knew what was going on. And we could get them done easier. Hodgkin's or non-Hodgkin's, diffuse cancer of lymph nodes. Now, this is next part of our lecture. This is a question that's missed 50% of the time. So I wanted to bring it out here. I'm going to bring it out again, and I'm going to explain to you what's the difference. So, Hodgkin's, non-Hodgkin's is cancer of lymph nodes. Hodgkin's, think about a Hodge is a lodge, a house, something you can see, touch, feel, smell. And it's above the shoulders. So it's painless swelling of lymph nodes above clavicles. I can see him and I can touch him. Diffuse means they're all over the place and I can't see them. They're little itsy bitsies all over. That is not a house. It's not a lodge. I can't see it. I can't feel it. That's a non-Hodge, okay? That's how you tell the difference. You're going to hear this one again. A Wilms tumor. What do we know about a Wilms tumor? And I'm going to go over it again for you. But a Wilms tumor is a tumor in the kidney, and the problem with a Wilms tumor, and this is the big nursing thing, is that that encapsulated type of mass, if we touch it and palpate that abdomen, little microembolus could be released from that tumor, so causing metastasis. So do not palpate the abdomen, leave it alone. Which child with a Wilms tumor, which action by a nursing student causes a faculty member to intervene? What's the student doing wrong? She's touching that good old abdomen. Remember, Wilms tumor is a kidney tumor. A lot of tumors that have to do with the kidneys, you always think kidneys are have a problem with blood pressure, right? Always correlate kidneys with, how's my blood pressure? This is a child who might get things like Phasitech or one of those medications to help keep those blood pressures down. That is Wilms tumor, kidney. An absolute contraindication for nasal tracheal suctioning include which of the following? What they're asking about is why would you put something in a mouth? You're going to create more swelling, and that's things that are problems. Epiglottitis, you don't want a problem. Croups already swelling. Tonsillectomy or could bleed back there. Iron dextran is given via which route? For iron deficient anemia. If you can't drink the liquid, they're going to be given, and you can't eat the food, you're going to be getting an injection. How is it being done? And it is a deep IM-Z track drug because it burns the skin and discolors it. Which cancer may present with painless, firm, and enlarged cervical nodes? It's above the clavicles. It's up here. Again, that is Hodgkin's lymphoma, okay? This is painless, firm, and large nodes. What happens with Hodgkin's is they get the cancer in the lymph nodes, and it grows, and it pushes against the esophagus, and it starts the patient coughing and even causing problems with eating and swallowing. That's when they receive treatment, and that's when they find it. A multi. When teaching about sickle cell disease, you would include what? So you got a kid has sickle cell disease. Remember, the big thing, what causes sickle cell disease? Blood vessels being too small. How can we take care of that so we can prevent these crises? Well, number one, you give this kid a bottle of water wherever he goes. Fluid, 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 fluid. Hydrate, hydrate, hydrate. If it's cold outside, dress warm because it will constrict the blood vessels. You want to keep them warm, keep them dilated. Of course, pain medicine is always given before it gets too bad because by the time they get to the ER, morphine, Dilaudid ain't going to help when they're that bad. And again, look at that immunosuppressed, the fever. They are immunosuppressed. They need to have medical treatment. Very good, guys. Thalassemia major is treated primarily with what? Cooley's anemia. They also have some facial figure disfigurement because the extra marrow in their bones and things. So you'll see like these big faces and stuff in thalassemia. But thalassemia major, Cooley's anemia, the only way we treat it is blood transfusions and chelation therapy. Last question. What is the most common opportunistic infection with children with HIV? And that is PCP pneumonia. One day nurse. Yay, you one day. And a Meg. Good job. Number one. Drum roll. Ding. Katie. And we got Madeline and a JC. All right, let's continue on with where we are. Mhm. Okay, now we have some cancer, things that we're going to talk about. Children, with cancer. So leukemias and lymphomas are most of them, believe it or not. It's not these solid things that you think of. Now, leukemia, what's leukemia? It's a problem with the white blood cells, right? It's cancer of the white blood cells, mostly boys. Now, there's something here. Down syndrome children are at higher risk for leukemia. I've talked about Down's children. They're cognitively delayed. They're more apt to get leukemia. They're more apt to get hypothyroidism, and they're more apt to have congenital heart disease. These poor children, there's extra stuff they have to worry about, isn't it? So, the definition: unrestricted proliferation of immature white blood cells in the blood forming tissues, which means the white blood cells are cancer and they're not doing what they need to do. So, what do we see? Well, I actually had a next door neighbor who ended up with leukemia. She was like 12 or 13, which is actually an older age, but she came to the emergency room. She had pain in her knee. She had bruising. She was tired, flu-like, and felt horrible. And when they did that, they did a CBC. And what they found was that she had leukemia. Her white blood cell count on arrival to the ER was zero point 0.1. It should be 7, 8, 10, somewhere around there, right? But it wasn't. So they did the blood, looked at the CBC, and then she was admitted, of course. They did a lumbar puncture because they want to make sure, is that central nervous system, is it with cancer? Is it not? We got to take care of that too. And again, bone marrow is going to be done. Be honest to your kid, it's going to hurt. Now, once we have leukemia diagnosis, they're going to put in a central line, usually a port, where they put somewhere under the skin, like either on the right or left side of their chest. And I've seen them in the middle. And it's under the skin, so you have to access it every time with this special needle. But it keeps stuff from hanging out and getting caught and pulling out these kids. It's under the skin, so it protects it. And what we do is we're going to do, of course, your lumbar puncture, make sure everything's okay, and then put in that line. And now we're going to do chemotherapy. Now, they give intense chemotherapy. 2, 3, it depends. The cancer depends on the doctor, what conference he's been to, what he's going to use. But you need to know induction therapy is about 4 to 6 weeks. Look at our goal. Our goal is achieving remission. So in the first 4 to 6 weeks, you're in remission, but they still continue steps 2, 3, and 4. And the reason is we want to make sure that the cancer cells are gone, that there's no sneaky, hidey little cells anywhere. So we take care of the central nervous system, they take care of wherever. And then, of course, there's a maintenance. Usually it's an oral pill at that point. Could be a year of it, 2 years, depending. Now, if it doesn't go away and we need to do more drastic, one of the treatments can be a hematopoietic stem cell transplant. You know, now at birth, we're all given that opportunity for our children to take the cord blood and save it. We've all been asked if you had a baby. Expensive as all get out, right? But if we save that, that is my stem cell transplant if I needed it. Now, if we have that, automatically it's the best for me. I want it. Autologous stem cell transplant. That's mine. Now, if I don't have anything saved, because not many do because it's so expensive, all the others are better, allogenic. And if we had to guess the second best, it would be siblings from the same parents, and then parents and grandparents, etc. But you don't need A positive, A positive, O positive. There is absolutely there's no match for a stem cell transplant. Here it is, does it work? So kid got leukemia. A lot of stuff's going to go on, like I said. We're going to be accessing the port, which is putting a needle inside the skin in order to get the blood from them. They're going to be getting chemo. They're going to be feeling terrible. All stuff is going to be going on with them. Our biggest thing is to prepare them properly, prepare them, make sure they're not in pain, and then prevent any of the complications. Again, it's red blood cells, it's white blood cells, it's platelets, it's all the above. So we got infection, hemorrhage, anemia. So again, be careful. Prognosis isn't bad, believe it or not. Um, Girls do better than boys, and there are different white blood cells. There's the ALL, the leukocyte, and there's AML, which is monocyte. That's the hard one. AML is harder than the ALL. It just is, whatever it is. The other thing is, what's your blood type? Are you abnormal or are you like the normal everybody has A positive, O positive? When you are that rare blood type, you're not getting that platelets, that blood, that what you need as quick as you can. That's the patient who doesn't do as well. So, cancers, we do chemotherapy, radiation therapy, and we do surgery. Okay. We know the signs and symptoms. We've gone over it before with my friend that was the neighbor, had pain, fever, ecchymosis, petechiae, and she was bleeding and she was tired and felt horrible. And that's what she came in with. Now, they hooked her up to all of that chemotherapy. In the first 5 to 7 days of chemotherapy, they go into this nadir type of thing where their neutrophils drop to very low. Now, what are neutrophils? Well, neutropenia means white blood cells, right? So their white blood cells are low, which means it can't fight infection. This is the most dangerous time. Now, the reason why I mention this, it's not just children with cancer that can have low white blood cells or neutrophil counts less than they should be. 500 is low. They should be like 2,000. I mean, that's the difference that you see. Any child with a neutrophil count of this number, and then in report, you find out the nursing assistant says, oh, that patient has 101 fever. That patient with 101 fever and a neutrophil count of 500 or less is your priority because that's patient about to crash and burn on you. They have no immune system. They're about to go into septic shock. Okay? Neutrophils. Important things. So in chemo, we know they can bleed because it's what the cancer does. We know they're anemics. We got to keep them quiet, calm them down. We're going to give them antiemetics because they're going to be vomiting, and then nutrition. Whatever they want, they can eat, as in high calorie, high fat, high protein, high carbs. Want every bite to count because a lot of them get mucosal irritations in the mouth, etc. So again, whatever they want. You remember to be careful. Some of these patients, their blood counts are so low, they're going to have severe side effects. You've got to be careful. We're going to be giving them pain medicine. Remember, pain medicine, you worry about constipation. So we also, constipation, you have to bear down hard. Their platelet counts are low. They're tend to bleeding. They have bearing down to have a stool, they're going to bleed in their brain and they can have a stroke. That's the whole thing that they worry about. They'll bleed into their urine. And of course, we know with any chemotherapy, it's always that hair loss. I've seen families cut their hair off. I always had little ribbons that I used to buy myself, bring them in and make these cute little ribbons. And me and that little girl, we would wear the same things, right? Send one home to their sister, and made it less of a, you got a bald head. Hey, I got to wash this. You make it a difference. And we know they get steroids, and we know there is always that Cushing syndrome. So be careful with that. Always, always, always prepare your child and be honest if it's going to hurt. Giving pain medicines, it's not just a narcotic. Remember, a lot of times it's just repositioning. If they're laying down, sit them up. If they need a pillow to splint, give it to them. And again, give them the medicine that they do need. Don't hold it. Kids do have pain. Health promotion and children with cancer is pretty hard. I think the biggest thing is those immunizations. What can they get? What can't they get? Be careful. Any immunosuppressed patient, remember, steroids make you immunosuppressed. Remember that with adults. That's a med surge 2 question. So they do not, when they're immunosuppressed, get live vaccines. Okay. So they can't have it. And maybe the family can't. You got to be careful with it. They can have those inactivated vaccines, they can have them. They're okay. And the big, big thing with cancer and vaccines is children, chickenpox is deadly to these patients. So they need to have that varicella vaccine. So here's Hodgkin's, non Hodgkin's. Hodgkin's is a lodge, a house. You can see it, you can feel it, you can touch it, right? There it is. Big picture up here, above the clavicles. Non-Hodgkin's, again, you can't see it, you can't feel it. It's like all over the place. So, again, any cancer can be, metastasized. What do you see with Hodgkin's disease? Painless, enlarged, firm cervical or supra above the clavicle lymphadenopathy. That means your lymph nodes are swollen above the clavicles. Because they get big and push against the trachea, you're going to see fever, anorexia, weight loss, night sweats. How do we diagnose it? Well, history number one, of course, you're going to do a lab test, but the biopsy. And the biopsy is going to show Hodgkin's disease, which is Sternberg Reed cells. Treatment, depending on it. If it's this big tumor, we want to shrink it before we get it out. Radiation. When don't we use radiation? Well, it depends on the child. If the kid's too tiny, we're not going to use it, okay? Prognosis can be good, but they are going to be infertile. Non-Hodgkin's, you can't see it. That's the whole big thing. But the treatment is the same. They're going to do radiation. They're going to do chemo. They're going to do surgery if they can. Okay. Brain tumors, most common of all the solid ones in there. What do we see? Well, tumor in the brain, it starts to get big. You're going to see headaches getting worse over time. You can see problems maybe with the eyes because it's pushing against them, like nystagmus. Maybe it's pushing against a motion, place in your head where you're walking. You're going to have that, moving weird. And then it could be even diabetes insipidus. It's the pituitary gland telling you, ooh, there's something going on there. And of course, the growth, and that's part of the pituitary gland too. So the symptoms, headaches getting worse, vomiting not related to feeding, and it's basically symptoms getting worse over time, and then all of a sudden you can't walk, etc. And we'll get to the point of doing biopsy. After they do that shrinking, shrink it down, they give that chemotherapy, and then we're going to do the surgery. We've got to be careful post-operatively. Post-operatively, it's all about positioning, and it's all about fluid regulation. You don't want to put over fluid in the brain, so intake, output, very, very important on these children. Monitoring, can I put them on that site that was on surgery? Can I elevate the head of the bed or not? These are things you need to check the order with. A neuroblastoma is something that happens where there's a tumor in the abdomen that gets big. And then when you finally find this in the abdomen, it's already in the brain. So it's a nephroneuroblastoma type thing. It comes off the abdomen, but it's already in the brain. Outcomes are not that great at all on these, and that's what you need to know there. Now, osteosarcoma, cancer of the bone. This is usually adolescents, many boys this happens to, where the femur bone gets a cancer on it. And then what do we see with these children? All of a sudden they get in pain in their legs. It gets worse over time. They start limping. Something's going on. Now, cancer of the bone, you have got to take the entire bone out. And most of the time, this is a femur. So you've got to take the upper leg off, period. Gotta go. Bye bye. So, what they want to do, the goal of surgery for osteosarcoma is to take the lower leg, put it up, turn it around, and reattach it so that there's a place for a prosthesis. So, the goal is to salvage the limb. I've already talked about Wilms tumor, retinoblastoma. This is like when you see animals in the distance and they're in the dark and you have a light on and you see the shiny stuff. This is what you see with the retina has a tumor in it. I've seen only one in my lifetime. And the whole thing about this is we need to make sure if there was what symptoms have been going on with this child. They do radiation. They put those marks on wherever radiation needs to go. Be aware you cannot wash them off because that's where they're going to insert and put the next dose of radiation. They want to keep it in the same place. So they do radiation, they do chemo, they do surgery, they remove the whole eye, and they can put a prosthesis into the eye. Germ cell tumors. This is testicular cancer. I've actually seen an 18-year-old boy come where he had waited for like 2 months to come in to be checked with testicular pain, and it had already metastasized all over his body. So, men, do your monthly testicle exam like we as women do our monthly breast exam. Liver tumors are not that bad, actually. Livers grow back. And then childhood cancer survivor rate, it's gotten better and better and better through the years. And I've been a nurse a long, long time. They are curing things they never did before. And I love going to Facebook or somewhere and seeing these signs. I'm free, I'm cancer free. And I wish the world was cancer free. Let's find that germ therapy or whatever it is, right? All right, we got one more thing to do, and it's a cahoots, and it's actually a shorter one, so we're good. It's only 19 questions, so we're all right. Who wants to win this one? Antoine, are you want to win this one? Maybe. Megan, how about you? You good try? Okay. Claudia, how about you? All right, let's get going. A child is admitted with neutropenia. What nursing action takes priority? Again, what's neutropenia? Again, sometimes it's just knowing what the term is, and you can figure out these answers. And it's all about hand washing. Neutropenia, I have a low white count. What does that mean? That means I can't fight infection. What does that mean for the nurse? I can't give you one. Let's wash my hands. What symptom would a healthcare professional expect to see in a child with leukemia? Yep, bruising because platelets are low, fatigue because the hemoglobin is low, pain because cancer, any sort of cancers, that's what it does cause. Very good. Child with Wilms tumor. Rejection by the nursing student causes a faculty member to intervene. Again, what is a Wilms tumor? Nephro tumor. A lot of times you got to control it with blood pressure stuff. Again, we're not going to palpate that abdomen. Your child with ALL has had a recent lab results with a platelet count of 10,000. Nursing action. What did I tell you about platelet counts of 20,000 and less? What's our priorities? Bleeding precautions, right? No platelets are going to bleed. And it doesn't matter ALL, doesn't matter a normal kid with sepsis. You're going to see low platelets. You're going to see low neutrophil counts with fevers. These are a problem. A child with ALL has a fever of 100.5. What should they need to do? It's another immunosuppressed child. Excellent. You need to tell the doctor why they need to be placed on an antibiotic. A child's having a bone marrow aspiration. What should you tell this child? I've seen quite a few bone marrows, and I can't get over that as they go into the bone, and it is scary. Again, making sure you're honest with your kid. It hurts. Most common clinical manifestation of a retinoblastoma. Again, it's what we call a cat's eye. It's because when you put a light in it, it just reflects back at you. It looks like years ago when they had those big flash cameras and they took a picture and your eyes turned white. It's the same thing. Of course, we don't have it anymore. We got lovely iPhones that take great pictures, but it is called a cat's eye reflex that we see that whiteness. Your child's been diagnosed with a retinoblastoma. What information is important? So you got one of those cat's eye going on, and I need to do an assessment on you. What are some questions am I going to ask? Again, what's been going on with your eyes? Is there anything that could have led up to this? Very good. Yes. A goal of surgery for a child with an osteosarcoma is, again, osteosarcoma is a cancer of a bone. The entire bone has to be removed, whether it's a femur bone or any bone, it's got to go. All right. So, what our goal with osteosarcoma with the femur is to salvage the limb because we can take the lower part and put it up. Now there's a place to attach a prosthesis. That's our goal, to salvage the limb because of that. We want to put something there to walk. A child's complaining about those skin markings for radiation should be told what? They got those purple things, remember the one above the eye? What are we going to do with those things? So those little markings tell exactly the next time when they go for radiation, where exactly to point the radiation. If we take it off, they've got to remark it. And now that radiation may not be getting to exactly where the first time or second time or whatever time it was. I used to do what we call washing off markings type of parties, and children used to love it. Whether it's on an arm, a leg, a high, or whatever, you mark them off. And the children used to love it, made fun from it. Again, distraction. What assessment question needs to be asked to a child with possible rheumatic fever? So we know it's all about strep. A child was to receive their own bone marrow. This is called a blank transfusion. Again, automatically me, mine, I'm the best. Good job. You like my jingle wingles. What cancer may present with firm, painless, enlarged cervical nodes? Painless, firm cervical above the shoulders. Absolutely Hodgkin's. Good job, guys. A multi. Treatment of an osteosarcoma includes. So, with an osteosarcoma, our goal is to salvage that limb, yes. But sometimes we can't. So amputation, we got to get rid of that anyway. That bone has got to go. If we can salvage it, that's the best. And yes, we're going to do chemo. Stem cell doesn't work for this. Stem cell is more the blood. That's more leukemia. That's more those things. It's not when we talk about a bone cancer. A multi. Who are the best donors for a bone marrow transplant? So we know the best one is always automatically me, mine, I'm the best, right? But again, the second one would be siblings. Then it would go to mom and grandma and down the line. But number one, me or my brother and sister from the same mom and dad, that has the best chances. What would you consider to be neutropenia or low neutrophil count in children? Hmm. What's the normal value of neutrophils? So neutrophils should be about 2,000. That's normal. 1,500, 2,000, somewhere there. When we see them less than 500, this child has absolutely no immune defense for them. And especially if they've got a fever, this kid's going to go into septic shock. Kid's going to go to the ICU immediately, or the adult, doesn't matter. Neutropenia affects all age people. A primary characteristic of a brain tumor is, what do you see? I've got this thing in my head growing. What am I going to see? And it's basically symptoms that become worse over time. Vomiting, not related to eating. Occasional headaches, no. Headaches that progressively are getting worse. And balance that now is progressively, I'm not as good as I was when I started. So it's symptoms worse over time. The optimum treatment for osteosarcoma is our goal, the optimum priority, what we would wish for is to salvage the limb because we want to have somewhere to put a prosthesis. We want this child to be able to get and be mobile. And if we salvage the limb, there's a place for a prosthesis that can work more effectively. Last question. A child is receiving induction of chemotherapy. What does induction mean? Remember, there's 4 stages of chemotherapy that we give. What does the induction mean? It's actually the initial stage, and the goal is remission. So in 4 to 6 weeks, cancer's gone. You're like, oh, woo, woo, great. No, we're still going to continue to make sure that there's no cells hiding and being sneaky. Number 3 is C. Number 2 is Katie. Good job, Katie, again. Number 1, drum roll, bing, another JC. We have a me and we have a Jess. All right, guys. So I've been through this week. I've done you okay. Now, I want you to all know that I will be going out of town tomorrow. My brother, 2 years younger than me, who my son is named after, born on his birthday, has died. And I'm going to his celebration of life, where I'm going to be with my entire family. I may not be answering you as quickly as normal. You always have Dr. Brown, and she's not a big bad bear. She's a sweetheart. And there's also Professor Morris that are backing me up. If you need me or have questions, send me a message. If I don't go back quick, it's because I'm a little bit, somewhere else. All right. But I am here for you. If you need something, reach out. You can reach to anyone. Everybody knows, and they're here to help you. Professor Morris will help you. Send a message to me if it can wait. If it can't wait, now, what I'm going to tell you right now, anybody who has not given me a diagnosis for their assignment and need one, send it out as soon as you can. In the airplane, I can answer you, right? On the way up. I'm going to South Carolina by Charleston. So I just wanted you all to know that. So if I'm a little bit, it's because of that. He had cancer of the lung. He was doing better. Cancer came back. He went into hospice on a Monday, right before Christmas, and Christmas Eve he died when I was in Mexico. And they didn't want to do anything until a celebration of life, where he's having his 4 kids, 11 grandkids, And there's only three of us Bogart originals left. I had six brothers. So the other two brothers will be there and all the kids. So anyway, just wanted you all to know I'm being open and honest to tell you what's going on. I will send you this recording. I will send you the cahoots. I will send you the review recording again, the study guide. I will take care of you before I do anything. Okay. Thank you guys. Have a
Thank you,
great evening.
Professor.
If you need
Thank
something,
you.
just holler, but I'll get there.